very good evening to everyone. Now, after such a detailed discussion about the retina, I'll shift to the another specialty, that is neuro-ophthalmology. So, I'll discuss all the OCT scenarios which can help us to diagnose a neuro-ophthalmological disease by doing OCT in such patients. So, I have no financial disclosures to make. So, this is the OCT printout which we usually get, and sometimes we are not able to see where to see. So all the areas, first one is the patient details, and here the signal strength is there. So we have to see what is the signal strength. If it is more than 7, then only it is the accurate to read this printout. And then comes these key parameters, including the average retinal nerve fiber thickness, the optic cup, disc area, rim area, everything. And then there comes the RNFL deviation map, the arrow. And this is showing the NNR thickness, and there comes the RNFL thickness as compared to the age match controls. So this is the actual, if you want to see grossly what are the deviated parameters, you can see here from the RNFL thickness how much it is different than the age match controls. And then in the lower area, there is a quadrant-wise RNFL thickness and the clockwise RNFL thickness. So how OCT help us about the diagnosis in neuro-ophthalmological condition? It is a surrogate marker of the neuroaxonal integrity in the afferent visual pathway. It helps us in diagnosing the conditions, disease monitoring, and the prognosticating the information about that disease. So most valuable parameters in the OCT for neuro-ophthalmology are the RNFL thickness and the GCL layer thickness. Starting with the first most important neuro-ophthalmological disease, optic neuritis. How OCT can help us? It is a quantitative tool to monitor the disease. And the initial spike we all know that if the optic neuritis is there, RNFL would be thickened in the acute stage. So this initial spike in RNFL thickness due to the flow stasis, exoplasmic flow stasis, can mask the earliest axonal degeneration. So for that, macular OCT, the macular volume and inner ganglion cell layer, these are the two factors which can help us to see whether there is any axonal degeneration or not, because there the edema will not come. So it is one related study done in Dr. RP Center, AIIMS, where they have evaluated the retinal nerve fiber thickness, and yes, they have concluded that it is reduced in the optic neuritis patient, the patient of multiple sclerosis, and it is definitely correlated with the visual parameters as well. So this study, I was part of the study in which we studied the multiple sclerosis early patients, where we had seen both the parameters, RNFL as well as the GCL layer thickness. And the conclusion was GCL IPL thickness was the more sensitive clinical parameter as compared to the RNFL thickness. And it is definitely much more correlated with all other visual parameters. So important point to note, there is a floor effect in the OCT. And OCT don't detect the loss of ganglion cell layer above 30 to 40. So if it's already the severe disease, above 30 to 50 micron thinness, it will not detect. So we have to keep that in mind, and we have to see the clinically correlation also. And after MS studies, there are a lot of other neurodegenerative diseases like Parkinsonism and Alzheimer's, which are studied with the help of OCT. So NMO spectrum diseases. It's very, the clinical spectrum of this disease is always very much overlapping with the multiple sclerosis. So we have to see a few other things to differentiate them. So OCT is one of them. In this NMO related spectrum diseases, one thing is the investigation purpose, the aquaporin 4 antibodies. In OCT, we can see if the mean RNFL loss is around 20 to 30 microns, it happens in multiple sclerosis. And if it is NMO, it will lead to the more severe loss, like 55 to 83 microns. And then in optic neuritis patient, there is usually a peripapillary, all the quadrants are involved in NMO, whereas in optic neuritis, mostly the temporal quadrant is involved. And in NMO spectrum diseases, high prevalence of microcystic macular edema is also present, which we usually don't see in the optic neuritis patient. So with OCT, we can differentiate these two entities. Now comes to the ischemic optic neuropathy. We can use to identify the treatment effects of NAION with OCT. The thickness of macular OCT and ganglion cell layer again is expected to provide a better structural indicator. In ischemic optic neuropathies like NAION, there is a report, in different studies it is reported the altitudinal pattern of GCL layer thickness loss, usually superior and inferior corresponding to the visual field effect in NaION, the ganglion cell would be like the superior or inferior loss. So you can see in optic neuritis is the whole peripapillary diameter is involved, whereas in NaION, if it is involving the superior quadrant only, then accordingly you can see the ganglion cell loss there. So there comes one patient, a 25-year-old female patient presented to us with the acute vision loss that was painful, and patient was of multiple sclerosis. So the suggestive diagnosis would be optic neuritis. So here you can see that was the left eye was involved, so we can see here the RNFL thinning in the temporal quadrant. So then the second case, this again the 21-year-old female patient presented to us after the resolution of optic neuritis after 3 months. So the fundus picture almost the recovered optic neuritis. Vision was also recovered to 6/6, but when we did the OCT, yes, it is showing the damage in the inferior quadrant. So OCT is always valuable even in the acute as well as resolved stage. So there comes the third case, which was 50-year-old male patient who presented with a sudden vision loss, which was painless, and patient had other systemic comorbidities as well. So diagnosis was ischemic neuropathy, optic neuropathy, and here you can see that this area, this arrow, yes. So here is the RNFL thickness, which is showing the thickened RNFL, and this because of the acute edema. But you cannot determine how much is the axonal degeneration already happened. So from here, the GCL IPL thickness, you can see that there is a thinning of the GCL. So we can estimate about the already the damage is there. So here comes the fourth case. This was a patient of again the NaION presented after the 3 years of attack. So here also there is a thinning of the RNFL. Because the patient has had an episode 3 years back, so here we can see the thinning in the RNFL level as well, because edema has all gone and it has set in the axonal degeneration. So now papilledema, this is also a very common disease which is benefited with by doing OCT. We can follow up the patient, we can prognosticate the patient about the improvement, visual parameters, how much they will improve, what we are expecting. So here also the RNFL measurement with traditional OCT cannot differentiate whether it is a disc edema which is now decreasing or it is an axonal loss, that is because of that the thickness is decreasing. So GCL thickness indicates the actual axons are dying off. So here is the one patient of IAH with papilledema, acute papilledema. There you can see there is a RNFL thickening. But when we had seen the GCL IPL, it is again in the normal limit. So we can prognosticate the patient that yes, you have the edema, but if we can treat this edema, the visual parameters can come to normal. So that is a good prognostic case. And the similar case who had presented with a chronic disc edema, the RNFL thickness was increased, but when we had seen the GCL, it has decreased in thickness. So not a good prognostic case. There are few other studies, Mark et al. They have proposed one another parameter. Like these two lines where they had shown the RP basement membrane layer, which showed the inward angulation toward the vitreous if there is a edema, especially because of intracranial hypertension. And they had shown in their study that this angulation usually decreases and straighten up if the ICT is getting decreased because of any treatment or medical treatment or the surgical intervention. So this I am showing the normal patient. Here you can see these are the straight lines, no angulation is there. But if we will go back, these are the angulation in the papilledema patient where there is an inward angulation toward the vitreous, which is a diagnostic of papilledema due to ICT rays. And in Mark et al. Study only, they have shown the sequential straightening of this line after the treatment in a follow-up of 12 weeks. So now comes the differentiation of other diseases like optic disc drusen from the papilledema. The most important thing is the thinning of RNFL and GCL in the optic disc drusen. Because clinically we see both the things are same. There is a edema, but when the optic disc drusen is there, it will show the thinning of the RNFL and the GCL. And there is another important point, subretinal hyporeflective space we can see between the RP and the choriocapillaries in the optic disc drusen. For Burritt, definitely enhanced depth and the swept source OCTs are the better one to diagnose. Similarly, in the conditions like LHOA and optic atrophy, we can prognosticate the patient by seeing the GCL damage, that how much is already damaged. Now, this is a little new thing, OCT in pituitary tumors. Studies done by John et al. And Costello et al., they have shown the nasal hemiretinal ganglion cellular thinning. This is the specific particular area thinning in such tumor. If you are in your patient, if you are doing OCT and you are seeing pattern like this, that is nasal hemiretinal ganglion cellular, then you should go for the imaging to rule out any pituitary tumor. So this is an important finding to see in OCT. So how to avoid the artifacts while doing the OCT? Firstly, confirm the name and the age of the patient. Age of the patient is very important. As you know, we are seeing the color codings, and that is the age matched. So if we have put the age wrongly, then our interpretation would be wrong. So check the signal strength, check the refractive error, look for any presence of any rectangular area, like here with the arrow I am showing. This kind of areas, this is usually because of artifact, which is not actually matching the clinical examination, that there is no defect or there is no anatomical distribution is matching. So such kind of things you can expect from the artifact. Cyclotorsion should be ruled out, and the thickness below 40 mm are typically due to errors in the segmentation. Especially like if you are seeing the GCL thickness, and here if we can see that this is average is 60, but minimum GCL IPL is 37 only. There is too much mismatch between the average thickness and the minimum GCL. This happens because of the error in segmentation. So this we have to keep in mind. Thank you so much. I would like to ask if there is any query about these OCTs. I would. Okay. Thank you.
Dr. Raju Hanswal.
You mentioned about the role of OCT in evaluation of the pituitary tumors also. Does it have any prognostic value? Like a patient has a pituitary adenoma, the surgeon is planning to do the excision. The patient already has some loss of vision and field defects. By studying the OCT details like RNFL and the GCL, is it possible for it to predict the outcome? There have been, I think, some studies shows that by accurately studying the loss, we can determine whether the patient is going to have a regain of vision. Is that true?
So as I already told, in OCT specific is the GCL layer thickness. So if that is damaged, it will not recover. So we can prognosticate the patient. Like in papilledema patient, edema will go. That RNFL thickness would be decreased over the period of time. But if the damage is already there in the GCL layer, it will not recover. So we can prognosticate accordingly. Thank you.